All right, welcome everybody. My name is Connie Jorsvik. I am a healthcare navigator and patient advocate and the owner of Patient Pathways. I've been in healthcare now for over 45 years, and on November 1st will be exactly 13 years since I started Patient Pathways, the first iterations when I sat down and wrote my business plan and began to get my first website up. And I didn't fully launch for another 3 or 4 months. So officially in 2000 and whatever 12 years ago was, but I started 13 years ago, and it's been a big moment for me in realizing how much has happened in the last 13 years. So it's the mission at Patient Pathways to provide you with detailed, accurate information about how to become a better informed, more empowered patient or care partner. Reach out for individualized, specialized healthcare, navigation, and advocacy services when you need support, you're overwhelmed, you don't have time. We are part of your team. This is how I make my money so that I can provide the free services that you're offered. People say, I don't want to bother you because you're already so busy, but this is how I support myself. So if you need me, please reach out. Call if you or a loved one is in crisis, but try to reach out early to prevent a crisis. All of today's information is now on the Patient Pathways website. And this is where, if you go to PatientPathways.ca, you'll find it under education. It opens like a book. So there are subsections and subchapters. And when you scroll down, you'll see navigate the BC healthcare system. And underneath that is all the information that you're going to receive tonight. This is my book, Navigating the BC Healthcare System. It's only available in ebook form right now. It is my mission right now to get it into print. And so that is why I'm asking for additional help in pre-ordering the books. And I'm hoping that I can have it printed by January. So before we start, I want to give you a quick word about advanced care planning, which is the basis for everything else. It's so important. Advanced care planning is not one document. It is a series of documents. It's an umbrella of planning documents that allow you to plan ahead for serious illness, injury, and end of life. Serious illness, injury, or end of life are going to happen to every single one of us. And it's certainly going to affect many people in our lives. Advanced care planning is important for all adults of all ages and all levels of health. I don't see a lot of people who are under the age of 50 attending these webinars, but it is incredibly important that they do. So if you've got adult children or other people in your lives who are under the age of 50, please encourage them to get their advanced care planning done, because people who are under the age of 50 are much more likely to have serious illness and injury than those of us at the end of life or in our senior years. So advanced care planning starts with thinking about your values and beliefs, and then having conversations with our loved ones and future decision makers. Over the next month, I will be putting on a series of 4 more sessions, and they're going to go through every single section on this. So by the 4th week, if you've attended or listened to the recordings, watched the recordings, we will, on the 4th session, actually put together our advance directive or a letter of wishes. And by that time, you'll know what I'm talking about. So if you're planning on attending, I ask you to make a commitment to yourself that you will actually attend or watch all of the recordings so that you're able to do that at the end. That is a $300 value that I'm giving you for free. And so I hope you'll make a commitment to do that. By the end of tonight even, I hope that conversations with your loved ones is something that you have at the top of your to-do list. Because after the conversations, then comes the documentation. So what is the documentation under advanced care planning? It's your representation agreement, which is the most important document. An enduring power of attorney is for finances and legal. And an advance directive or a living will or a letter of wishes for medical care are highly promoted. The things that might not apply to everybody are medical orders for scope of treatment, which is known in the healthcare industry as MOST, a no CPR order, which is a do not resuscitate order, and if you're expecting to, or you might die at home, an expected death in the home form is incredibly important. I will be going through all of that next week under advanced care planning. So navigating the BC healthcare system, part 1, doctor's offices, emergency rooms, and hospitals. Before I launch into that, are there any questions that come up about representation agreements? Was there anything else in the chat, Sean, that I need to know about?
Nothing so far in the chat.
Okay, thank you. It may be years before our healthcare system resumes any semblance of normal. There are just so many things that have come at the healthcare system from so many angles. I kind of call it a big pile of cooked spaghetti. You pull on one and another place breaks. The biggest problem is a lack of people. And there's also a lack of money to bring those people on board. There's time, how long it takes to have anybody trained. So there's a whole bunch of things that are going on, and it might be 10 or 15 years before we develop any sense of normal. So as patients and care partners, we must plan to do the heavy lifting in our own care. And I'll be talking about what that means. So this is kind of what the healthcare system looks like. It's a diagram, a graphic that I put together that shows all the different pieces. There's community health, emergency rooms, specialists, hospitals. There's testing. There might be BC Cancer. There might be home care and palliative care. There might be residential care or hospice. The biggest thing in all of this is that there are dozens, if not hundreds, of little circles within each one of these circles. And that those little arrows, those little purple arrows, are called transitions of care, where your information is being transmitted from one place to another, from one form of care to another. It's those transitions of care that are the most likely to have communication breakdown. And that is where you need to be the most diligent. As I go through this, you're going to, there's always somebody who says it's not fair and it's not right. You are absolutely correct. When we are sick, we need the healthcare system to hold us tight, to put us in their arms, and to allow us to just surrender and be sick and to get better. The problem is that there just aren't enough people and it's moving too fast. It is just a reality, and we have to step into that reality. The other thing is that our healthcare system is system-centered and not patient-centered. There's a lot of talk in academia about patient-centered care, and that's been going on for as long as I've been in the healthcare system. But it is a system, and what that means is that when you walk into a doctor's office, when you are referred to a specialist, when you go to the hospital, you are basically a number in that system. You are a room number when you are in the hospital, and they're looking at getting you off for tests. They're working at discharge planning, and they really are not considering you as a human being. The only person who is seeing you as a human being, and only mildly, is your nurse while you're in hospital. And the rest of it is you're just a cog in the wheel. And so it's important that you take care of your own needs. So in order to get the care you need and deserve, deserve. Do your homework on your health conditions and your medications. Understand the system before a health crisis. Build your own team. So building your own team is having your family on board, understanding what you need, what you want, what your values and beliefs are. It might be, if you've got a cancer diagnosis, for instance, who is going to be taking you for your tests? Who is going to be picking you up after your chemotherapy or your radiation? And you can actually recruit team by phoning, say, HealthLink BC, and talking to dietitians and building out your team. It's so important that it's more than just you. Empower those on your team with a representation agreement, and we'll be talking about that more next week, and all of that's on my website as well. So you and your care partner must ensure your own safe passage from one point of care to another. This will be a skill testing question. I'm actually going to get you to say it out loud to me later when I get to various points. It's so important to be proactive and be assertive, not passive and not aggressive, just that beautiful middle ground of assertive. And follow up, and then follow up some more. Healthcare communication is an absolute mess. Miscommunication, but most often missed communication at all levels of the healthcare system are so common that incidents are dismissed and just considered normal. When I call a nursing station at around the magic time of 10:30 or 11 o'clock in the morning, and I phone and I talk to a nurse, and she'll say, who has had that patient for now 4 or 5 hours, she goes, I haven't had time to look at their chart. This is my first day. The problem is that that is likely the only day that she's going to have with that patient. And we'll be moving on to a different patient load the next day. So those first days happen all the time. Communication is often just notes at the front of charts. And if nobody looks at those notes, then they're missed. I have had a client this last week where the family was desperately trying to get a hold of the nurse for 4 days before I stepped in. And it took me 4 or 5 times within a day, and multiple messages were on the front of the chart to please call the son, to please call me, and nobody was getting back. So it's a really big job to get that communication going. It's all because our doctors, nurses, and allied professionals are too busy and overworked to communicate with each other. This can lead to significant errors, which are too often life-threatening and can be life-ending. You and those who speak for you, hopefully your assigned representative, can be a part of the solution in preventing errors in communication. Be prepared with a thorough health care plan, a medical history, and current medications, and give a copy at every point of care. So every point of care is the paramedics who come to your home, the emergency room or the emergency department, then the hospital, and every unit within the hospital that you go. It doesn't mean you have to give a copy at every point of care. You just want to make sure that they have received it. So when I call a nursing unit or go in person, I go and I make sure that medical history and current medications are on file and they've been reviewed. I have a client who is a frequent flyer in the emergency department at Vancouver General, and he's got a friend and I who are his team, and we make sure that every admission and every change in his medical care, everything is up to date and it's in a plastic sleeve, and one of us gives it to the paramedics when they arrive at the house. And every time I go and see him in the emergency room and I see his plastic sleeve sitting on his lap and nobody's taken a look at it. So it's very, very important that you make sure that your nurse sees that information, that the paramedics look at it when they're home, they're taking you to hospital. It's your job to make sure that they're seeing that vital information. When you have concerns, tell them to someone who's in a position of responsibility. So I don't generally recommend that any big concerns be told to your regular nurse. They are moving too fast. They've got too many things to do. So tell them to a doctor, to a charge nurse, or a manager, as often as it takes to see action. If you need to phone 3 or 4 times in a day, if you need to phone every single day, then that's what it takes to make sure that that information is paid attention to. Last week, a family member said, I called the social worker on Monday. It's now Thursday. I haven't heard anything. That information has gone to the bottom of her to-do list. She has triaged and found out what is the most important. And so you need to keep you at the top of the to-do list for the people on your healthcare team. Be vigilant, be assertive, and follow up. And when you're tired of following up, follow up again. A notebook, and I'm about to show you my notebook. This is my handy dandy notebook. And I've had 2 iterations of this book. I can't see myself, so I can't see whether I'm showing you the right thing. Just a second. So this book, I've had 2 iterations over the last 13 years. I've gotten it through Staples. You can only buy it on their online now. But it's got pages that are removable. So I can take them out and I can store them someplace else and add them as I go. It's got places, it's got markers that you can get, so separations. So I highly, highly recommend have a dedicated notebook so that you don't have 2 or 3 notebooks on the go about your healthcare. Try and have it in one book that you can use continuously over time. A notebook, when you use well, can save you significant time, stress, misinformation, and appointments. It may even save your life. You can say, but Dr. So-and-so said on September the 1st of 2022, blah, blah, blah. And that prevents miscommunication. I was at 3 appointments today with my clients, and there was miscommunication every single step of the way with every single client. But I had their information in my book, and I was able to bring the doctors up to speed. It's incredibly important. If something goes wrong, you will have all the information you need to file a complaint. But if everything goes right, and I hope it does, it will give you the names for thank you cards and chocolates. Studies show that we retain as little as 7 to 17% of information 10 minutes after leaving an important appointment. But what is more significant is that we color remembrances with emotions that can shut down forming accurate logical memories. If the doctor is cool, dismissive, or distracted, we tend to quit hearing what they've said. I was with a client in the emergency room last week, and she didn't have a GP. She was in a position where, an emergency position where she didn't have enough prescriptions to see her through. And so there were various things that she needed to go to the emergency room, but that was one of them. And the doctor said to her, why don't you have a GP? And she said, well, because my GP retired. And then the doctor went on and did all the work and got the prescriptions and sent her a couple of requisitions. And I sent her an email the next day following up. And she said, I don't remember any of that, Connie, but I do remember that the doctor didn't believe me when I told her that my GP had retired. I had not heard that at all in the doctor's voice. And so it's important that we try and be logical during our appointments and hear what the doctor is having to say. And if we're in an emotional position where we can't do that, then take somebody along. Your notebook needs to go with you to every medical appointment, every test, and every hospitalization, and then readily available for reference. Get in the habit now, even if you have no serious health issues. You are the keeper of your health history. We simply don't know what medical history from our past will be relevant for our futures. Keep a running file of past consultations and testing results that can be incredibly important for your future care. So every time that you go for a mammogram, every time that you've had a colonoscopy, ask your family physician for copies of those and put them into a file folder. You don't need to take them along with you, but in case you need to pull those up in the future, it's important to have them. It's so important that if you have a piece of metal in your body in particular, that you note that. Whether you've got metal in your teeth, you've had a clip put in an aneurysm in your head or your heart, you've got a stent, or you've had a joint replacement, or anything like that, any metal is so important that is written on your healthcare history, because if that's the case, you will not be able to have an MRI. They can do a more detailed CT scan, but if you have an MRI and you haven't identified it, those huge magnets that they use will suck the metal straight out of your skin. So that's an example. If you've had cancer in the past and you've had treatments, it's also important that you have what those treatments are, because you might not be able to have them again. They'll cause a severe allergic reaction. Just going to take a look at the chat.
Still no change.
Okay. So doctor's offices, where is this? And most of us know how to conduct ourselves in doctor's offices, but things have changed in the last few years. So how to get better care at doctors and specialists' offices? It's harder than ever to see our family practitioners in a timely manner, if you're lucky enough to have a family practitioner. And seeing a specialist can take months, sometimes years. It is essential to go into appointments prepared. So if you've been waiting 6 months to a year to see a cardiologist, you need to write down the questions that you need to ask, because you will not see that cardiologist maybe ever again, and certainly not for another 6 months to a year. So you can't leave and then go, oh, geez, Louise, I forgot to ask. So it's important to write that down. Be proactive and assertive can make the difference between rapid care and undue pain and suffering, and even death. So when I was a cardiac nurse, I was involved in a special study, and we phoned people up to see how long they had waited on the wait list, how they were doing, and the number of people who told us that their loved one had died while waiting on the waiting list. So again, you're going to follow up. Plan ahead for all health appointments. Take a notebook and write notes during the appointment or immediately following. Write down and prioritize what you need to talk about. And for any appointments where you're getting complicated information or instructions, that's called an information-dense appointment, such as if you're going to a cardiologist or the cancer agency. Take someone along with you to take notes and help you ask questions that you might have forgotten. So when I attend an appointment with somebody, we go over the questions ahead of time. And then I coach them that towards the end of the appointment, they turn to me and they say, did I forget anything, Connie? Or I will say to them, Sally, you were going to bring up blah, blah, blah. So that person is indicated that there's more that they wanted to say, because those appointments are intimidating. Use a calendar to plan appointment dates, especially if the follow-up is 2 or 5 years from now. So if it's luckily, when for us women, the mammogram thing comes every 1 to 2 years automatically through our mail. But for other things, like you want another colonoscopy in 5 years, it's important that you're following up on those things. So specialists' offices. Get faster referrals to specialists. If the future of your health depends on seeing a specialist, be proactive and be assertive. Definitely not aggressive. Specialist triage, which means sort based on the information they receive. The more information your doctor puts on the referral form, the better. If it's urgent or emergent to see a specialist, ask that your GP what information they provided to support that. Often when I go to patient appointments with them, the GP will actually say, I have marked this as urgent. They're the ones who are putting that down. And then the big thing that most of us feel uncomfortable about is finding out and following up on that referral. We are told, oh, you'll hear something in the next few months. But it's important to find out who your referral was sent to. Often that takes a week or so. So phone back to your practitioner's office and see where it was sent. If you haven't heard anything within a week, check with your doctor to ensure the referral was sent and who it was sent to, even if there is a message that you will be contacted in several months, or ask your doctor to confirm that the referral went through. So when I'm doing this for somebody, I actually write out ahead of time, I've got the patient's information, and I'll say, hi, my name is Connie. I'm phoning on behalf of Mary Smith. Her date of birth is, her personal health number is this, and I'm just phoning to confirm that you received the referral. I will assume that if I don't hear from you, that the referral was received. That way they don't have to call me back, and I leave my phone number. So I'm going to put somebody on the spot. Heather has been working with me for the last several weeks as a practicum student, and some of you might have been on her webinar workshop on last Saturday. But Heather used to be a social worker, and she has done this on her own. And we've had a conversation about this particular part. And so Heather, I was just wondering if you can give some more insight on this incredibly difficult part of the healthcare system.
Good evening. Thank you. So for myself, I have worked professionally in the healthcare system, but I am also can be a frequent flyer of the healthcare system as a patient. With that in mind, everything that Connie has said, yes, like definitely be assertive, definitely advocate for yourself. And the part about the communication is, when I was once in the radiology department, and on the same floor, like maybe 15 feet down the hall was the cast clinic. So if they wanted an x-ray of their patient, they would fax it to us at the radiology department. Well, most of the time that fax got lost in that 15 feet. So they would just manually bring that down when it was requested. Yes, beware of the fax machine. So it is really important to follow up with any appointments that are made with a specialist. They'll say, oh yes, as Connie said, they'll get to you, they'll call you when they're ready. I usually give it about a week and follow up and say, hey, just want to make sure this got through. And then I also like to add that if there's any cancellation lists, put me on that as well to see if that can kind of speed things up. But yes, really truly do follow up with it, because the intentions are good. Things get lost. Things don't go through all of 15 feet in the magic electronic world. So please do, yeah. I speak to that passionately, follow up with that and advocate for what you need. And also I want to say, if anything changes with your health between the initial visit and the referral and when you're to be seen, and things, start worsening, follow up with your doctor and also the specialist as well. I've had these changes. I'm experiencing more pain. Whatever it is, that will also help them determine, okay, can we move this person up to this space or not? It's a communication thing, good, bad, and indifferent, but advocate, and follow up.
Thanks, Heather. So at least 1/3, and Heather and I have talked about this, might be even close to half of faxes do not go through or are misplaced. Why in the world do we use fax machines in 2023? There is a law in British Columbia and in most provinces that information is not to be transmitted across a border of the province. It's not supposed to go to the United States. It's not supposed to go to Ontario. That rule gets broken all the time. But if you are using Google or Microsoft or any of those other things, your information in an email, your information is automatically going across borders. And the healthcare system is not supposed to do that. There is a lot of work ongoing on that, but even emails get lost. I lose emails all the time, and I am only receiving 20 or 30 emails a day. So if you're receiving hundreds of emails a day, that's going to be a problem. So it's important that you follow up. Fax machines have been linked to unnecessary deaths because they're not followed up. And never assume that your fax made it to the specialist's office and was handled appropriately. So Heather might have actually done this presentation by herself, because if your condition worsens, tell your GP and ask that they update your referral. If your chest pain is getting worse, tell them about it. Don't just tell your GP, tell your specialist. Phone them and say, hi, my name is Mary Smith. I am supposed to see Dr. Jones about my chest pain. It is getting worse. And describe it to them and leave your information. And the number of times that causes, oh, we've got a cancellation tomorrow, is quite astounding. So emergency departments. Get the care you need in the emergency department. Take your healthy history and a list of medications. I would hope that it goes without saying to be responsible, to not go to the emergency department unless it's an emergency. But I see it every single time I go, that people are coming in for things that are not emergencies. There are urgent care clinics within Vancouver and beyond. Those are the places to go if you have something urgent or emergent that doesn't need life-saving care. And the biggest thing is to pack your patients. Take a blanket, take a warm sweater, take a book. Ask if you can have a bottle of water that you've brought or a snack. Take your headphones, take your cell phone, take your charger, and expect to wait a very long time. But if your condition worsens while waiting for care or while in care, tell any nurse. So if you're sitting in the waiting room or you've been given a birth in the emergency department and people are walking by and nobody seems to be paying attention to you, tell any nurse if your concerns are getting worse. This is especially, the next few points are especially important for women. We tend to be more passive about being sent home. So be assertive if you're being sent home and ask for clear answers about your concerns. Why do you think it was this? Why do you think it was that? What should I do? When should I come back if things are not getting better? Before you leave, confirm that your report is being sent to your family practitioner so you can follow up. And then follow up with your family practitioner as soon as possible, because they are not automatically informed. So, and sometimes the emergency department will give you a week's worth of medication, such as antibiotics, or maybe pain medication, or something else that's important. And they're saying to follow up with your family doctor. And then you phone your family doctor and they say, we can't get you in for 2 weeks. Tell them that you only have 7 days worth of medications and that you were told by the emergency department to get in to see your family doctor. You don't want to be waiting another 7 to 10 to 12 hours in another emergency department to get those medications refilled. If your symptoms or your issues are not improving, or go back to the emergency department. Never ever feel like you are a bother, and don't dismiss your concerns. So hospitals. So as you've likely seen, I've been going step by step how you might go through the system. And a lot of people have, the majority of people in hospitals, it's an unplanned admission. So when you go to an emergency department, everybody who's sitting in that emergency department was not expecting to be there that day. And most of them were not expecting to be admitted to the hospital. Hospitals are fast-paced with frequent staff turnover and care is fragmented. Improve care and communication in hospital, knowing that the hospital system moves fast. The turnover of nurses and doctors looking after you can be dizzying. And a lot of the time they are caring for you without talking to you. I was talking to a brand new graduate, a licensed practical nurse, and she said that she was shocked that they were not taught to walk into a patient's room in the morning and introduce themselves. It's really important. If your nurse doesn't introduce themselves, then ask who they are, ask what their name is. Nobody should be providing you with care without you knowing who they are. Even though you are sick, you need to be on top of things. And this is a brief summary how to do that. So who's who in the healthcare zoo? There are a lot of different animals in the healthcare zoo. Find out who the nurse is who runs the unit on a day-to-day basis. The name of that person is different in just about every hospital and every unit. Vancouver General Hospital, for instance, has patient care coordinators, head nurses, patient care coordinators, nurse managers, charge nurses, and they're all the same thing. So basically, ask for the charge nurse. Write down, and I'm mainly talking at this point to people who are the care partners or the caregivers for that patient. Hopefully you have somebody on your team who's doing that, who's advocating for you. So if you're the care partner, write down who is the charge nurse, and then find out what the local or the extension for that unit is, and write all of that in your notebook. Wherever possible, have someone with you. This is especially important for us seniors to keep an eye on your condition and be assertive about gathering information. If you are the care partner, a loved one, a representative, find out who to talk to. A charge nurse or a social worker are often the best bets. I have put an entire education article together on my website called Who's Who in the Healthcare Zoo, and it gives you a step-by-step guide to who all these people are. The healthcare system is not obligated to update loved ones and substitute decision makers. This comes as a really big shock to people, but I thought back to when I was a nurse, and I do not remember ever updating a family member unless the patient was actively dying or had died. Nurses are just too busy to pick up a phone and talk to families. So it's up to you to be the person to talk to them. Plan ahead and put a representation agreement in place, because your representative is entitled to assist you while you are capable and able to act as you if you are incapable of making your own healthcare decisions. Give your nurse a copy of your representation agreement and ask that it be put on the front of your chart. Let your healthcare team know about any advanced care planning wishes and documents, and we'll be going over that again next week. Take a notebook and document dates and times. So this is for the patient as well as the care partner. You're going to take your notebook, and even though it's a lot of work, the names of all the doctors who visit you, the specialist, the hospitalist, which is the hospital GP, and the residents. In all of our big hospitals, Lionsgate, St. Paul's, Vancouver General, Royal Columbian Hospital, Richmond Hospital, all have residents who are mainly looking after your care. There can be first, second, and third year residents who are looking after you, and you can't tell the difference. If somebody comes in and mumbles, "Hi, my name is Dr. blah, blah, blah," and you didn't catch it, do not hesitate to ask them for their name again. "I'm sorry, doctor, I didn't catch your name. Can you give it to me?" I don't know why. All of them hide their name tag, or they've got them on backwards. So don't hesitate to ask for that, and then make notes about who that person is, especially if they are getting your consent for surgeries or treatments that are going to be invasive. Make notes about recommended changes in care, medications, treatments, and surgeries. And what are the plans for treatments and surgeries? 99% of the time, I'll walk into a patient's room and I'll say, "Hi, Marge. What's happened today? Have you gone for any tests? What did the doctors say?" "Well, I went somewhere and they did something. They took some blood this morning. The doctor came in and mumbled something. I have no idea what's happening." And that's a good day. If I get any of that information, what mostly happens is go, "Oh, it was a flurry of activity," and they don't know what happened. So as a very, very empowered patient, it's so important that you write all of this stuff down. Be assertive and ask questions, even if you think that you're going to be a bother. The biggest transition in the whole healthcare system is hospital discharge planning. You are likely to be discharged before you feel you're ready. That doesn't mean that you shouldn't go home. Home is best. And sometimes you will get better faster if you're at home. But you're likely not to feel like you're ready to do that. And it's important to know that the hospital will be planning your discharge the moment you're admitted, and you need to do the same thing. This is the one time where no news is definitely not good news. Having a representative is massively important at this stage because a temporary substitute decision maker, your spouse or an adult child, if you have not legally named them, will have little or to no say in whether you are able to manage at home or if you need rehabilitation or residential care. I have actually seen it with my own eyes because I've watched. I've been with one of my clients and they are definitely not able to look after themselves at home. They don't know how to get their own medications, their own groceries. They can't get themselves to the bathroom. They might have not have gotten up in the hospital at all. One time I stood by, I left the room and I stood by and I watched a bed control nurse walk into the room and say to my client, "So Sally, would you like to go home?" And of course, every single person says yes. That does not mean that the adult is capable. And so that one actually really, really riles me. And so I get phone calls from sons and daughters saying, number one, I didn't even know dad was in hospital. And number two, they're sending him home tomorrow and he cannot manage by himself. Without a representation agreement, you really have no say at all on whether that person can go home. When you hear those stories of the little old ladies who are being sent home at 3 o'clock in the morning in a hospital gown, that is why it happens. And it's so important that you tell the people at the front desk, my representative is my daughter, Samantha, and that they know that Samantha is to be called. Okay, I will take myself off the soapbox just for a little bit. Doctors have little influence on when a discharge will take place. Families ask doctors all the time, "Doctor, when will my mom go home?" As soon as the doctor says that mom is medically stable, all bets are off. And the doctor might say another few days, and then you find out the next day that mom will be going home. So find out who will make the decision. You can just phone the charge nurse, that handy little charge nurse, and say, who's responsible for discharge planning? And they will put you through to the right person. And ask about planned discharge dates and keep on following up. You want these kinds of decisions to be made on a Tuesday, a Wednesday, or a Thursday, and definitely not on a Friday, because on Fridays, everything goes to pot in the hospital. They're trying to get people out. There isn't time for you to go and get equipment from Red Cross. There are just so many things that can go wrong on Fridays. So keep on following up. So now we're getting into is your loved one really ready to go home? So be aware of the home first policy. All hospitals are mandated by the provincial government to try and send the patient home with home support before a transfer to assisted living or long-term care will be considered. Only if the patient fails to manage at home will residential care be considered. If you are going home, will you need home support? What other supports will you need to go home? Often the occupational therapist is the best person to discuss your home situation, what kind of equipment you will need, whether you might need a lift or a commode beside your bed, whether your wheelchair will fit through the door. They can do a requisition to the Red Cross for temporary free equipment. And the social worker is often the best resource if additional care or long-term care need to be considered. And again, this is all in the Who's Who in the Healthcare Zoo education article. So do you have the right equipment? Ask about any special equipment you will need, such as crutches or a cane, walker, wheelchair, shower bed, hospital bed, maybe a lift, and where you could rent or buy it. So occupational therapists have all the lists of where it can either be borrowed for a period of time or the equipment vendors, and even lists of people, vendors who can give you rebates. So where do you find it? How can you get it installed? And the biggest one of all is, will a wheelchair fit through the doorways? So if you or your loved one is an extra big person and you need a wider wheelchair, they hardly ever fit through a standard doorway. So it's often overlooked, and it's a very serious problem. You've gotten that person home and the wheelchair doesn't fit through the door, send them back to hospital. How long until you will be assessed before services are put in place? So it depends on the time of the year. This is the trifecta time of all the respiratory viruses. Hospitals are filling up and overloading. And so at times like this, it can be a couple of weeks before a case manager will be able to see you at home. So what will you do until those services are put in place? Do you need to consider private home care services in the meantime? And does any training of family caregivers need to be done before discharge? And what if home is simply not the appropriate choice? Well, number one, if this is the case, this is the time that you pick up the phone and you call me, because this is the biggest time that you're going to need some help. Is a rehabilitation unit an option for extra time to recover and get stronger? There are very few of these available. They use those for people who really, really cannot go home. And what does long-term care look like, and how long will that process take? Sean.
Connie, thank you. I'll just do this as well. As a newbie to the long-term care process and navigating all of this stuff, would you be willing to just talk a little bit longer about what a rehabilitation unit is?
Sure.
Thank you.
I'm going to talk much more in a few minutes, after a very short break in a couple minutes, about home care and long-term care specifically. But rehabilitation unit there are only a few of them, and they're very overburdened. So in Vancouver, there's Holy Family, which is down at Fraser near Marine. And there is a unit out at UBC Hospital. In New Westminster and Burnaby, there's Queen's Park. So these are places where people who just need, hopefully, more time and more rehab are transferred to. The issue around rehab is that they get the same amount of money per patient as a hospital does, and they just reallocate it a little bit differently. So there are more physiotherapists, there are more occupational therapists, there are more rehab workers rather than nurses. And so I actually don't get into this very much, but rehab is a place where families need to be extra vigilant because there's not a lot of nursing care going on. But it can be good for a lot of older people who've broken a hip, who've had a knee replacement, who've had a stroke. They're often sent to rehab. Does that help?
Yeah, absolutely. I'm learning that it's a place, not a team of people, and that nursing care isn't happening because they aren't technically nurses, or there's less nurses at these kinds of
Yes.
places. Okay, thank you so much.
Okay. So what does long-term care look like, and how long will that process take? And I will be following up with that after our very short break. So before we talk about home care and residential care, it's time for questions and a short break. So I'm going to stop share and I'm going to pause the recording and Carol, you're the only person I can see. So a thumbs up that we're back to one screen. Perfect. Thank you so much. So navigating the BC healthcare system, part 2 is home care and residential care. This is private and public. So this is when you have left the hospital system. And this is probably the most confusing and underfunded of all the healthcare systems. So when a loved one's physical or mental health begins to decline, start doing your homework on the process of home care and residential care. It's a daunting, often long-term task that can push families to the brink of physical, emotional, and financial collapse. Good communication and kindness for the entire family team is essential, but often not there. When I put up this slide, people kind of looked blankly at me. And I tried to figure out how I could make it abundantly clear why it's important that when you are saying any of these red flag statements, we're managing, we're figuring it out, or we're muddling through, why those are statements that you need to pause and wonder about. Do you have any bandwidth for a crisis when you're like this? So my mother was the primary caregiver for my father for almost 30 years. And he was the standard roller coaster, up and down, but never quite up as far as he came down. And it was just this constant roller coaster from the age of 61 to 91. And she managed. She was muddling through. She was figuring it out day by day and hour by hour. And then as he got older and older, I would get more and more frequent phone calls. They lived in Kelowna. I lived in North Vancouver at the time. And I would get a phone call saying, I've had to send your dad to hospital. Say, Mom, do you need help? Yes, please. And the number of drives that I made on that Coquihalla at 2:00 in the morning to get to her, because by the time he was in hospital, she was exhausted and she was beyond where she could manage anymore. And so if you're saying you're muddling through, what do you have as a backup plan for those times when a crisis happens? A serious and complex illness or advancing cognitive decline are not something that any of us can do alone. One of the things that you'll notice that I do in my seminars is I rarely use the term dementia, because it's not just Alzheimer's or Lewy body dementia or vascular dementia. It's anything, and it's a million shades of gray in advancing cognitive decline, where somebody just can't think through the normal activities of daily living. And so that's why I use that term. And it's the thing that most of us will have to deal with when we're in this healthcare system, and especially when we're looking at home care and long-term care. So understanding home care. Community, public subsidized home care. Home care is non-medical assistance for activities of daily living, such as bathing, dressing, transferring, and eating. Under this, bathing is usually bird baths with a shower once a week. And if you can imagine that if a person is incontinent of bowel or bladder, they get raised to 2 showers a week. Can you imagine only getting 2 showers a week when you are incontinent? Anyway, it does not include any housekeeping, laundry, meal preparation. Caregivers will heat prepared meals and serve it, and it does not include shopping. The usual amount of time is 2 to 4 hours per day, divided into 2 to 4 time slots. Those are generally 20 minutes a time. There's likely there will be different caregivers every single visit, and this is a significant issue for those with cognitive decline. A different person is coming in every time that they're seen. And I personally can't imagine being one of those caregivers and walking into a new home every single day and having to orient yourself to where the microwave is, where the bathroom is, where all the caregiving supplies are. And you've got to do all of that in 20 minutes and leave. It is really no wonder that we have a profound lack of caregivers, paid caregivers. If nursing care is needed for medical reasons, such as wound care after surgery, or maybe a pressure sore, or if physiotherapy or occupational therapy are required, they are provided at no cost and are arranged separately by your community case manager. So there's a misconception about what home care is. They think it's nurses coming in to see them, and it's not. These often, if you need to have a nurse see you, you're actually asked to go into the central location for that wound care. And only if you really, really, really can't get out of your house will somebody come into your home. If the adult is at home rather than a hospital in the time of need for home care, absolutely anyone, including family or the adult, can request home care. It does not need to be ordered by a physician or a social worker. Please see the contact numbers in the education blog, Understanding Home Care. If you have not heard back in a week, or if the situation is getting worse, call back and keep on following up. So there's a central intake number for most of Vancouver Coastal Health, as well as Island Health. And you will leave the name, your name, the name of the adult, their date of birth, their personal health number, and what's going on and why you need to have somebody see the adult. I have seen that this particular job is done by a lot of people who are part-time. So if you phone on a Monday and that person is working Monday and Tuesday, they put that person down on their list, and the person on Wednesday, Thursday, and Friday does not follow up on that list. So they all have their own lists. So if you have not heard back in a week, keep on following up. If the situation gets worse, follow up and keep on calling. British Columbia is the only province where home care is not paid for, where it's not free. It is public subsidized, and you as the most people will pay a cost for home care. Home care is based on income, not assets. So it doesn't matter if you are renting an SRO in the downtown east side, or if you've got a $5 million home on the in Point Grey or in the British properties. It is based on income and not assets. And that's really, really important. And it's so important that you're talking to a financial planner on how to bring down your income. If you're selling your house, if you are liquidating assets, talk to a financial planner so that there's less income coming through. The other important point is the income of the spouse is added together. So the case manager will be computing both people in the household, even if only one person is receiving services. Public home care is free for those who are receiving the guaranteed income supplement. But for everybody else, home care, even though it is a certain amount of your income, can be a significant expense when adults are living on a fixed income. This forces too many people to decide that they need to go into long-term care too soon, because $300 or $400 a month in home care expenses will put them over the financial edge. You are expected to use savings and draw against the value of your home if you can't afford this out of your monthly income. Heard this from the seniors advocate, I've heard it from her mouth, and I've heard it from the Minister of Health, that you are expected to draw against your assets. There's often a question about CECL, and so I just wanted to bring this up. CECL is Choices in Supports for Independent Living. This can be an option where there is somebody in the household who can act as the administrator and the manager of private care staff that you are bringing on yourself. So if it is being, if they will, the government looks at care staff as being the equivalent of about $45 an hour. And so if you are getting 20 hours of care a week, then you are given the equivalent of 20 times $45 an hour. And then you can make that go further by hiring somebody at $20 or $25 an hour. It's a lot of work. I've only done 2 of these applications in my 13 years. I would not do one again, even if somebody was paying me to, a lot of money. It's daunting. Funding is only provided for those who are likely to live at home long-term and not for those who are expected to need residential care in the foreseeable future. So CECL was invented for people who are, say, quadriplegic or paraplegic, maybe have other long-term disabilities that they will be staying at home for a long time. Just quickly check the chat. A final important note, that is, if the adult is experiencing physical or cognitive decline and the need for residential care, such as assisted living or long-term care, is projected, it is important to bring in community supports as early as possible. The adult must be known to community health and requiring supports of some sort in order to be put on the list for public subsidized residential care. So I encourage you to go to the article, Understanding Residential Care. This is a really big issue, especially for women who are looking after a spouse who's at home, because they're used to looking after everything. Men are much more prone to or able to ask for help than women are. But women will help their loved one get in and out of the shower. They will help them with their meals. They will help them with their dressing. And they will say, we're coping, we're muddling through. It's important that at least one activity of daily living is taken over by home care. And usually that starts with a shower. So even if it's a shower once a week, that person is then known to community health and can be put on the list for public subsidized residential care. Yes, Sean.
This is me in the newbie sense again. Maybe a little bit of clarification for me around quotations, be known. What does it mean to be known to the community health? Is it the same as he is a known offender by the police? Is like
Yes.
he's in the system somehow already?
Yes, exactly. So that basically you have to have an open file going with home care in order to be put on that list. I don't think it's right. I think that there are a lot of families who are providing sports on their own, as long as you can say, I'm helping my husband with his daily showers. He couldn't eat without me. And certainly if somebody is bringing in private home care, I think that that should count and you should be able to prove it. I have advocated for a couple of families where that was seen as the case and I won, but it does take advocacy to say, my husband is being, we have brought in more and more home supports for him for the last 2 years. And it's because your services were not enough. I would really, really, of all the things that I would love to be an activist for, this is probably the one that I would like the most. The Ministry of Health knows that they don't have enough home care available for people, and yet they're putting this incredibly huge bar up for people to cross when it's not enough. And I hear about this one all the time. So if you know anybody, maybe you've got a um, direct line to Jimmy Pattison or something, please do let them know that I would jump on this bandwagon. Does that help, John?
Sort of. What does one need to do in order to become known?
To phone the home care, to do a central intake, to phone a home care branch and say, hi, I'm phoning on behalf of my husband. We need some support at home. And they will have a care manager come in and do an assessment and find out what they can do.
I see. Okay, so it's not like some referral from a hospital when you've gone in for emergency, they'll refer you, and therefore you're in the system and you are, quote, known. You can just be out there in the world struggling with something, and you can call and make yourself known.
Exactly. So there are two ways in. One is your own referral to a central intake line, and then I'll be talking about the hospital referrals in just a moment.
Awesome. Thank you so much.
Anybody else while we're here? Okay.
I just mentioned that doctors can do it too.
Yes, they can.
But
But
that's how we did it. Yeah.
yeah, but it doesn't have to be a hospital. It doesn't have to be a doctor. It doesn't have to be a social worker. Families can do it themselves. So I've put in dozens of referrals for people as well. So it can be anybody. It can be a neighbor or a friend saying, hey, I'm seeing Joe and Mary struggle, and they could really use somebody. So anybody can put that through. This is the one slide that I keep on forgetting to put someplace else. So that had to do with hospitals. If the adult can't manage at home and private home care is not a financially viable option, keep on taking them back to hospital, or take them to hospital if they're not managing. So as part of the public system, home and palliative care and hospice are part of the same system. Home and palliative care and hospice, this is provided through the same community health agency as regular home health. So if you've already got a case manager and your loved one is needing more help, they're now in a palliative care stage, or they are approaching end of life, then that case manager will take that up and then just add to your care. But if somebody is being told that they are dying or at the end of their life, anybody can put through a referral, but they must be deemed palliative or end of life by their family practitioner. There's very specific forms that need to be done in order for this, the palliative care to be in place. But when the designation is in place, the adult's conditions and needs are supervised by a special nurse caseworker and a team. Generally, the doctor does not become involved unless the family practitioner, there isn't a family practitioner, or the family practitioner is not available. And if you're in a situation like this and you think that somebody needs palliative care and you're not getting the answers you need, please don't hesitate to send me an email or give me a phone call. I've dealt with this a lot, and it's just too much to try and fit into a small, short seminar like this. When you have been deemed palliative, home care and home equipment, such as a hospital bed, commode, and a lift, and medications all become free. If the patient wants to die at home, 24-hour-a-day supports are supposed to be available for the last 72 hours of life. But this I actually should change this. This will be limited due to staffing issues. the palliative care nurses will come in wherever possible and try and teach families how to give things such as narcotics to their loved ones. And Sean, I'm going to get you to jump in here because I know that you've been through this. I know that it was Ontario, but tell people about, that last bit and how much you were expected to take on.
Yeah. Let's see. I feel like I just naturally asked the right questions of my mother's oncologist when she was struggling with her breast cancer return. And so a lot of this stuff was dealt with it just kind of started to happen. I asked the right questions and they gave me the numbers of the community health organizations that I needed to contact. In terms of the last things that you were talking about, in terms of my taking care of my mom, it was a very casual conversation. The question was put to me by a community nurse. Are you feeling comfortable delivering injectable medications into your mother's arm? And I said, I'll do whatever's necessary. And so she taught me very quickly, this is what you need to do. And I know I botched it a number of times because every time I gave my mom her morphine, I wasn't going slow enough, or I was going too fast, not fast enough, or and she was clearly in distress. And so after a day or two of that, we spoke to the next nurse that came that day and just said, look, this isn't working. Can we put in a stent? And that changed everything. It was all of a sudden very easy to deliver the medication, and I felt I could manage it. But if it had been more of what we had been going through, I know I would have struggled more and more with it, because the more I saw my mom struggle with receiving the medications, the more I questioned my ability to do it. Now,
So the palliative care team are supposed to be available 24 hours a day by phone for situations like that. And we won't go into that too much. I just wanted your input on, that sometimes families aren't prepared for that level of intervention that needs to be involved. And one of the things I want to say is that you can always ask for your loved one to be transferred to hospice. And I know that that was a big issue for you, and we're not going to go into that tonight, but going, if you're at home with your loved one and it's just simply too much, hospice should be an option for most people, but sometimes it doesn't work.
We struggled. We had some great nurses, and we had some nurses who were clearly overworked and just there to do the thing and get out again. They were nice, but their level of sort of bedside manner was to be lacking. We struggled to get a personal support worker to come in, and then when we finally did have one scheduled, they were unskilled, we'll call it. I actually had to help this PSW.
PSW stands for personal support worker. Yeah.
Yeah. I had to help her do her job. I don't know if she was new or if she was overworked as well or what have you, but yeah, and had my mom not died when she did, we were prepared to contact the community health group and just request somebody else and make sure that she didn't come around again. Very rough, very hand-fisted, I guess, is the word that I want to use.
Oh, that's so unfortunate when that happens. I'm sorry that happened to you.
Yeah, thank you.
Yeah,
I was okay to do it. if it had escalated and there were more difficult things, I think I would have kicked up more of a fuss.
Thank you for sharing that, Sean. Before I move on, I wanted to say that I'm almost finished with the home care piece. I want to talk about private home care. That'll be about another 5 minutes. Then I will be talking about long-term care. If I didn't post it properly in the in my reminders, this is actually a 2-hour webinar. So we will go to 8:30 for those of you who want to stay on for the long-term care piece. The residential care piece. If that doesn't matter to you, then please feel free to just say your goodbyes in the chat, or do a shout out and say goodbye. And I will, because the long-term care piece is very specific for those who are near that point, because it's too much if you're not near there. Okay. So the same staffing issues that are at play in regular home care are the norm in hospice and palliative care. The caregiving staff are often undertrained, as Sean has just pointed out, in palliative and end-of-life care. Some community health programs have more resources and staff than others. They all have the same dollars per adult, but they can spend it any way that they want to, and some places just don't have the home care and palliative teams. And that's something that you should be asking if your loved one wants to die at home. What kind of support do you think that you'll get? So back to all caregiving. If you need non-caregiving support, such as housekeeping and shopping, call or visit the website for BC 211 or dial 211, or call your local senior center. And they have Better at Home, which is housekeeping and shopping. They have transportation services and things like that. Be aware that the housekeeping in particular can be a year to a year and a half wait for somebody to come in, and it is not free. It is also based on income. So now you're paying for home care, and then you're paying for housekeeping on top of that. It can be quite the huge bill for some people. So I'm going to go to private home care, and this won't take too long. So more and more adults and their loved ones are turning to private home care agencies to fill in the massive gaps in public home care. The pros are consistency. If caregivers can't attend, it's up to the agency to fill that shift. Ask about their policy and their availability. I have found that some of the smaller communities do not have as many care staff, and so they are not able to necessarily fill that shift. Caregivers can do whatever needs to be done. That can be companionship, it can be physical care, meal preparation, housekeeping, shopping, and errand running. Hours can be increased as need increases, and most agencies can provide 24-hour-a-day care. But the big con is the expense. Rates are generally $35 to $50 per hour, depending on the city and the agency, and cheaper is not always the best option. Most agencies have minimums of 3 to 4 hours per shift. And so what that means is if you need somebody in the morning and then you need somebody at night, that is 2 shifts per day and at least 3 shifts per week. So this can add up to tens of thousands of dollars per month. It's actually cheaper to put somebody into private pay residential care than to have 24-hour-a-day care at home. Not all private care agencies are created equal. You must do your homework. If you have any questions about this, there are a couple of agencies that I absolutely love. I don't get referral fees from anybody, but there are agencies that I know that will step up and provide incredible care. So if you have any questions about that, please don't hesitate to reach out to me. Understand the options for home care now. It will reduce your stress later, especially in the case of sudden decline. Be proactive and be assertive. So if you don't need assisted living or long-term care now or in the future, you can pop out. This part will take us about 10 or 15 minutes. So sometimes being in assisted living or long-term care can really increase a person's sense of well-being and their quality of life. But it's not all fun and games. And so I'm going to go through some of the not easy parts, which is basically getting your loved one there. So people think that there is a graduation. There's living at home, going into independent living, going into assisted living, and then going into long-term care. Assisted living is a piece that most people will completely bypass. Assisted living is only appropriate for those with physical disabilities when they need assistance with activities of daily living, and home care is not an option. So assisted living is for those who are in wheelchairs, but generally they're fully capable of thinking through getting themselves to meals, directing their own care, directing their own medications. So it's usually physical disabilities only for those with assisted living. Care is non-medical to assist with dressing, bathing, and transferring, and provided largely by registered care age, or in some places, personal support workers who have even less education and training than a registered care aide. Residents must be able to direct their own care, and in most facilities must be able to do their own personal laundry and get themselves to and from meals and activities. If the adult is in assisted living and then has increasing needs, especially if they're going down they're having cognitive decline, additional community or private pay home care may be put into place in the assisted living to augment care until long-term care is available. But those in assisted living face the same wait list as the general public. The long-term care is the same as residential care, extended care, and complex care. Basically, what that means, all those mean that there are nurses on site, either licensed practical nurses or registered nurses all the time, 24 hours a day. There might not be a lot of them, but they're there. Within long-term care is special care unit. And those are for people who are at risk, usually have advanced cognitive decline, advanced dementia, and are at risk of wandering, or they have behavioral problems such as crawling into bed with other residents, or being physically aggressive. For everybody, if you're going to long-term care, it is usually the last step in your life. If public subsidized care is what you are seeking, home care will have to be explored and maximized first. The wait for long-term care is very, very long for public long-term care. So while long-term care is often the last home for aging adults, and they are likely to die in long-term care, it is best suited for people who are approaching the end of life from the aging process. Long-term care is not appropriate for adults who have a life-ending illness such as late-stage neurodegenerative diseases like Parkinson's or ALS, or metastatic cancers, because staffing levels and caregiving experience are not high enough. In these cases, palliative and hospice care at home and in facilities should be considered. So if you know somebody who's got advanced cancer and they're talking about going into long-term care, it's not the place for them. The most important, difficult, stressful step is deciding what facility is best for the person that we love. All facilities, whether public or private, are to meet the same minimum care requirements, and care is no different for someone who is receiving public subsidized care and those who are paying privately. In fact, the Seniors Advocate of BC stated in 2020 that the average amount of care provided in private pay facilities was lower than public subsidized facilities. So understanding the choice of public subsidized long-term care, you have a choice, sort of. Note that a representation agreement is massively important at this stage, but must be put in place while the adult is still capable. So If somebody's starting to go down the cognitive decline route, try and get a representation agreement in as soon as possible. So see their blog, Who Will Speak for You Representation Agreements. When the adult needs long-term care, families are asked to pick their top 3 facilities. The top 3 are all equally ranked. So if you're in North Vancouver, for instance, there are only 4 or 5 facilities that are available, and you pick the top 3, and whichever one of those comes up first. Pasha, I'll get to you in 1 second. A decision about long-term care is made by priority access, a centralized system for all health authorities. And why I bring that up is because nobody is able to say, could you get me to the top of the list? Because basically it is managed by a computer, and nobody can change that. Pasha.
I just wanted to mention that legally capable and mentally capable are not the same thing.
Thank you.
Mentally capable is a much higher standard. Legally capable, you just have to really barely understand what power you're giving away, and you can do the POA and the representative agreement. And I mean, one of my representees was definitely deep into dementia. He didn't really understand what she was saying, the lawyer was saying, but she let it go through anyways because there was nobody else to take on the responsibility. But just to make that people know that that if your person is diagnosed with dementia, it doesn't mean that they can't go ahead with the documents. They still might be legally capable.
And I will bring that up next week when we're talking about advanced care planning. Thank you so much for that, Pasha, because it's so important. I helped somebody with a representation agreement last week who I really had to dig deep to understand if he understood what was going on, but he was clearly able to say that he wanted his wife to be the person who would look after him, even though he really struggled with other things. But we will talk about the difference between a representation agreement 7, which is more for people who have some issues with capability, and a representation agreement 9. I will go into that a little bit next week. Generally, I don't touch it when somebody's got cognitive decline. I don't like to get involved with that kind of decision. And so if that's the case, then I certainly ask a lawyer or a notary public to step in. When the adult needs long-term care, families are asked to pick their top 3, and a decision is made by priority access, and I already said that. So interim beds used to be called first available bed, but the legislation has changed somewhat. When there is a need to move to long-term care and it is urgent or emergent, especially when the adult is being placed from hospital, the adult will be put on the interim bed list. It's an emergency bed list. There is little or no choice in accepting what interim bed they're getting. The adult, they used to be able to go anywhere in the health authority. So sometimes people in North Vancouver would end up in Richmond, or people in Richmond would end up in South Vancouver. Now, generally, it's seen within the city within the health authority. The adult remains at the top 3 wait list, and when one of those beds becomes available, the family has the choice of taking that bed or not. But by that time, I have found that the adult has often adjusted to that interim bed. So public subsidized care has a cost. It's based on income and not assets, and is 80% of the individual's income, and is not a combined household income, as is the case for community care. It's to a maximum of approximately $3,500 per month, which is a lot cheaper than $15,000 or $16,000 for a private pay bed. But even at that cost, it can be a heavy toll for households where one person goes into care and the other does not. Suddenly, 80% of that person's income is gone. Families and individuals are fully expected to go into savings and to draw down from the value of their home if that's what is needed to manage that expense. It can be a tough pill to swallow for those who are financially living on the edge. And it's especially difficult for women who might be living another 20 years after their male spouse has died. And all of a sudden their assets have been drawn down and they are living on a lot less money. So on to private pay. It is divided into both nonprofit and for-profit, which is a big change and there has been a big change since the pandemic. Most private nonprofit care facilities lease most or all of their beds to the health authority. Before the pandemic, it was these private nonprofit facilities such as Kiwanis, there St. Jude's Anglican Home, a lot of religious facilities are nonprofits, and they would lease about 50 or 60% of their beds to the health authority. And then people would come in and they could pay for private care to get in earlier. And then when a public subsidized bed became available, the paperwork was simply changed over and the person didn't have to leave. But with the pandemic, the nearly 100% of beds have now been leased by the health authority. And so there isn't as much of an opportunity to go in as private and then change over to public when a bed becomes available. And none of the private pay for-profit care facilities have public subsidized beds. So those are the Amicas and the Riveras and the Sunrises and various private pay for-profit care facilities. So private pay care costs are usually based on the amount of care required and the location of the facility. The higher the land values and the taxes are, the more the care will cost. So in North Vancouver, which is the most expensive in all of British Columbia, it is Sunrise in Lynn Valley is currently $16,000 per month at the top end. And the same care in Comox is $7,000. So it really depends on where you are. Assisted living can range between $6,000 to $12,000 per month, depending on location. And long-term care can range between $7,000 and $16,000 per month, depending on care requirements and location. So I'm almost done. Private pay all-in-one versus a la carte. Some private pay facilities have everything included in the same price. Care, no matter the level of need, the food, the rehab, and the activities are all one price. And that is what I would recommend if anybody needs this kind of care. I think that a la carte model should be banned. Not a lot of things that I am adamant about, but this one should be. The a la carte model is only offered in facilities that are exclusively private, and the costs go up as the care needs go up. It might seem like a more affordable option when somebody is at a lower level of care, but fees can skyrocket with a sudden health issue. The worst I've ever seen of this was a family contacted me, and mom and dad had gone into a private long-term care facility, and mom had advanced dementia, but dad was pretty up and around. They got a shared room, and he was able to get her to and from meals, to be able to help her with her medications, to help get her ready for bed every night. And then he fell and broke his back. And suddenly he needed to go into his own room. They both needed to go into private rooms. Both of them suddenly needed to go up to the highest level of care. And they went from $12,000 a month for the two of them to $30,000 for both of them within 1 week. We needed to put in an emergency transfer to a public subsidized bed because otherwise they were going to be evicted. I think that should be against the law. Off the soapbox I go again. So all of today's information is now on the Patient Pathways website under Education Blogs and Navigating the BC Healthcare System. And it is all available in detail in my book, Navigating the BC Healthcare System. And that link is in the bottom of all of my emails to you. So thank you for attending. I welcome your comments and feedback. And I really thank you for being here for the most intense of all of the workshops.